Hi, Mark.
Great to see you, Grace.
Welcome to the Heal with Grace podcast. I really appreciate you coming on.
I got to tell you, when I got your invite, it was a really fortunate time. I will do a little digression for a brief moment.
Okay.
I'm in a part of a study group at my church, and we were reading this book, What's So Amazing About Grace by Philip Yancey. We really were covering this book. It's
Oh,
about
wow.
you having grace in our lives and grace for other people. And your
Yeah.
email pops up, and it's like, here's a grace asking me to participate. I said, this is just like a sign. I would love to participate.
I
Nice to
love
meet
that.
you, Grace. And I imagine you're amazing as well.
Thank you. Thank you. I've really grown. I mean, I use my name obviously in the title. I've grown to really, really value it and understand what it really means. I think as
Yeah.
a kid, I didn't think much of it or didn't, yeah, I don't know if I really liked it that much, but there's a lot of meaning behind it. So,
Yeah, and we could use a lot more of that in our lives, in our world, our country.
yeah. Yeah. So, first and foremost, for people that do not know, can you give us a little background about who you are, what you do, and how you got into this work?
Sounds good. I'm a clinical psychologist, and I've long been interested in medicine. I was once a pre-med student who decided to not go to medicine, but to go to clinical psychology. But I've been interested in how the mind and body operate together for a long time. And started working I made a decision at some point early on in my life to, unlike most of my peers who went into hospital systems or private practice, I went into the academic world. So I've
Mm,
been at Wayne State University in Detroit, major university since 1991.
mm,
And when I went there, I had no interest in chronic pain. As a matter of fact, I had a professor in graduate school who said, I will quote her, I hate chronic pain patients. They never get better, and I feel so useless. And I said, okay, I will not go in that direction. And I didn't until I got to become a professor, and a bunch of my students said, we'd like to do our doctoral dissertations on people with rheumatoid arthritis, or people with fibromyalgia, or people with non-cardiac chest pain, or people with inflammatory bowel disease. And I had a whole bunch of these students interested in this topic. And I said, I guess I better start learning something about chronic pain. And that led to this career, which has really moved in the direction of understanding what's driving chronic pain. I've long been interested in emotions and what happens when people are not aware of their emotions and they don't express them very well. Is that a problem? Looks like it is. And I've been interested in methods of things like expressive writing and done a lot of research on that over the years with Jamie Pennebaker's work, and a lot of research on what happens if you ask people to write about difficult, emotional, stressful experiences. And in the past 15 years or so, I've moved into the direction with my colleagues of doing work in developing a therapy that would tackle those emotional processes, those discomforts. If those things are indeed driving some people's chronic pain, then can we fix those emotional issues and reduce or eliminate their chronic pain? And
mm.
that's where my work has been going.
There's many of us who, myself included, who have their own history of chronic pain, chronic symptoms, right? Going into this work. I'm the same. Never in a million years thought this would be my specialty, being a therapist. Do you have any of that experience for yourself?
Yeah, I didn't give you too much personal stuff in that little story, did I? It was mostly the sort of straightforward professional stuff. Most vivid memory of a mind-body issue for me was fourth grade science presentation in elementary school. The teacher was showing a movie of blood transfusion, or actually hemodialysis. And the blood was going out of some patient's arm to a machine and coming back again. And I remember watching this going, I don't feel so good. I'm not going to make it. And I walked out in the hallway and I barfed. And I sat there against the lockers, embarrassed that I had barfed, but also sort of curious, like, how the heck did that happen? How the heck did something go in my eyeballs and change my body around and come out? So there's that. Over the years, I've actually, especially when I was younger, weekends, going away for like a scouting weekend or something, my intestines would shut off on Friday afternoon and then return on Sunday afternoon when I'm pulling into my driveway back home. It's like the intestines said, we're in an uncomfortable place here. Let's stop working. So chronic pain in the usual sense, no, I haven't had much in the way of headaches or back or neck ache, but I've had these other sort of things, and they've been a curiosity to me and things I've worked on. By the way, I did my doctoral dissertation on overcoming blood phobia. And
Really?
yeah, I guess we do me search sometimes on our own issues, but became very interested in that phenomenon.
Yeah. This is just going to be a side note because it's not what the episode's about necessarily, but what did you find within that? I'm personally curious as that's something I've very much so dealt with.
Yeah. So first thing is two things. When the people who tend to have the blood phobia,
Hmm.
fainting experience, vasovagal syncope, tend to
Hmm.
be people who can experience another's pain or body almost personally, like high empathy. There's a high empathy piece. You see somebody else's broken body or blood coming out, and you feel it within your own arm or leg or whatever.
Mhm.
The other piece to it is that it happens when a person feels helpless. So there's a state of you have to sit here and take it. You can't fight or flee. You know, the fight or flight response. If that fight or flight response, that sympathetic drive, gets turned off and has to be terminated, all that's left is a response, a parasympathetic response that drops your blood pressure, and you start to faint. So if we could actually fight or run,
Yeah.
we would actually keep our sympathetic fight or flight system activated, and we keep our blood pressure up, and we wouldn't faint. So you can take people who have to sit there and give blood, and
Mhm.
I actually have a son. I think it's okay for me to say this publicly. Sure, he had a lot of blood work done when he was a kid, and he had the same thing that Dad had, and he'd start to pass out. And what I actually had him do as his dad, I'd say, take your other hand and pound it, and take your feet and pound it like you're fighting something, while they have to keep taking blood out of you. You'd watch his blood pressure stay up. If you stop doing that, he'd start to go down. Like, fight again, son, and even yell a little bit. Ah, stop! Would allow the activation of the sympathetic nervous system to keep his blood pressure up and get through the blood draw procedures.
That's fascinating.
It's
I've
kind of
I've
cool.
never made that connection. That's something I've dealt with many, many times, passed out many times by getting blood taken, and I've learned to work with it by soothing and calming. I'll put on a meditation or music or kind of distract in a way.
Yeah, distract. Yeah,
But still, that's I've never tried the fight
yeah.
response.
It's a fascinating phenomenon. So there's a fear thing that kicks in, which one makes you fight or flee. But there's
Yeah.
also a response, a parasympathetic thing that wants to shut your body down and protect you. And when your head says, "I'm stuck and I can't yell, fight, scream, or anything," that gets turned off. It just leaves the decreasing blood pressure parasympathetic drive, and then
Yeah.
you feel it. So my
Interesting.
recommendation is yell and scream and fight a little bit while you're being exposed to one of
Mhm.
those stimuli that normally would make you go.
Okay. All right. Interesting. Thank you.
Give it a try.
Yeah.
And by the way, you might think, what's that got to do with what we're talking about today? Well, emotions are important, and
Mhm.
the truncating of emotions, the blocking of them, turning them off can be a problem, and the experiencing and expressing can be adaptive sometimes.
Yeah. So let's talk a little bit more then about I'm just going to introduce then EAET, emotional awareness and expressive therapy, which you've helped develop. Can you explain a little bit about that and how that's helping people with pain and chronic symptoms?
Yep. So my colleague Howard Schubiner, who's a physician, we've been working together nearly 20 years now. And as we got into this world together, he came at it from John Sarno's perspective of it's something about the mind and the brain, and it's not your body that's diseased. I came in it from a perspective of psychological therapies that tackle emotional issues, like exposure therapies for trauma or fears. We started working together and said, how are we going to, put our minds together and help folks if there's trauma or conflict or interpersonal problems in people's background, and that seems to be driving some of their pain. And so I'm being a little cautious with the language, because it's not all people, it's not all types of pain, but there's a meaningful subset of folks who have backgrounds, and what they've done with their emotions is usually not given them some full adaptive expression, full experiencing. They've sort of worded them off or blocked them or something. So we started working together, and initially with a group of patients with fibromyalgia, and he was doing his thing and I was doing my thing. We got together and said, let's make a new thing. And we called it something. Initially, we called it something called emotional exposure therapy. We thought we would expose people to their emotions, but that turns out to be EET, and that looks like eat, and nobody wanted to say that, sort of thing. And also, too many people have 3-letter acronyms for their therapy names. So I basically said, let's come up with something that sounds more like what we're actually doing, which is awareness of emotion and expression of emotion therapy for chronic pain. I will confess that's a lousy name, EAET. Nobody can remember, too many vowels. It's too long. People like 3, not 4. And if I were rebranding it, I'd come up with something better. But here we are. So we've been doing a series of studies, Howard and I, and a number of other colleagues. And it's a very different approach than cognitive behavioral therapy or acceptance and commitment therapy or mindfulness-based therapies. It really does try to help people. We start with a model of what it is we think is going on with pain, which is current pain neuroscience model. It's the brain is the organ of pain, and it's reading some signals from your body, some sensations, but it's integrating it with a lot of other stuff, your beliefs, your fears, the models in the society, what the background stuff you're preventing yourself experiencing, sort of the threats that might be looming up from the back. And it creates an alarm system called pain. And
Mhm.
for some people, acute pain, it's a pretty good representation of what your body is going through, but chronic pain, it's usually a poor representation of what your body is experiencing. It's more about what your brain has learned or is expecting. And so we start with that educational piece, and then we start to get into a life history with people. Let me go through your whole life. And by the way, it's stunning how many patients have seen doc after doc after doc, and they don't know the professionals have never learned people's histories. Tell me your story, Grace. Take me back. The good stuff and the challenging stuff since you were, age 1. And then as we hear that story, tell me about health issues, pain, or other things that happened. Your parents got divorced then. You had this bad experience in high school. What were you experiencing? Many patients will start to see these connections between what happened in their lives and the various health-related challenges they've had. We'll look at you have this back pain right now or neck pain or whatever. When did it start? Well, it really blew up when I was in college. What was going on? Well, I was struggling with my so-and-so. And many patients, the majority that we see, have stories that start to make some sense, that the pain doesn't just, not this just injury, boom, pain, but there's a backstory to it. And then we start to take people to the next step, which is, let's look at your emotions that you have connected with some experience. So you had this really, thinking of a recent patient, you got this new job and the boss was vicious, a tyrant, and you ended up having chronic pain about a month later. Let's go back and replay an episode with that boss here in the safety of our session. And this time, I'd like you to sort of get a hold of whatever it is that you're the feelings that come up. And this is a really important point. The feelings are often, there's like 2 classes of feelings. There's the feelings that people often bring into therapy. Feeling like crap, hate myself, I'm feeling down, I'm anxious, I'm on edge, I'm irritable. And that's what they bring in. That's what they say. But underneath that are usually some feelings that are healthy and adaptive that fit the situation. So your boss was a tyrant and humiliated you and whatnot undeservedly. What other feelings are in there? Maybe there's a part of me that's mad. Good, let's activate that healthy part of you that's mad. And we'd help them feel it in their body. We'd help them start to give it some words and even use their body to do something, as opposed to their body sitting there doing nothing. Emotions want to have a body that's involved. Anger wants to do something with the hands and the face and the voice, and sadness wants to do something with the tears. And love wants to do something that feels like I want to hold and grab onto. And the last one we're looking at is some sort of self-compassion, which really needs to do something like this and something like this. And what I'm looking for is what emotions are hard for a person to experience and express, what are uncomfortable or anxiety-provoking. Hence the connection with what name makes you least comfortable calling me as we started this. But if we look at that issue, I'm looking for what emotions have been sort of blocked or buried, and they're usually one of 3 types. The anger-related emotions, the connecting feelings like sadness or love that bring you closer to a person, and the positive self feelings like compassion and pride. And when I see that it's hard for a person to experience or express those things when they should be able to in like a certain situation, then that's the direction that we go to help them develop more comfort with those feelings. So that's sort of it in a nutshell.
Yeah. What do you say, just piggybacking on that last part, what do you say when I get this a lot. Well, I've never really been an angry person. I just don't have that. That's not me.
I start with, wow, you're the one. I thought there might be some human out there. I haven't met many before. What you mean is that you don't experience anger, right? Are you the fortunate one who's never been in a situation that you were treated wrongly or put in a weird, uncomfortable spot and answered, well, I suppose I was, but somewhere in there was anger, but it got blocked or something. And I actually will take a person. One of the things I like to do is say, what would it be like for you, Grace, who doesn't feel ever becoming angry, to right now raise your voice and say, you're wrong, Mark, stop that. I'd invite a person to do that. And it's amazing that even faking it, that little role play, many people will have a lot of anxiety even doing that. So is it you don't ever feel angry, or it's scared to experience it and give it some voice becomes the question.
Yeah. Yeah. It's uncomfortable when you've never been able to do so or allowed to do so or never learned how.
Yeah. So those things, it's been blocked and I've been allowed to, I've had to suppress it. Then you'll see the anxiety bubble up when a person starts to,
Hmm.
and when I invite them to try something that sounds or looks a little like.
Yeah. Can you speak to I also get this question a lot of, well, okay, I can understand maybe emotional expression is important, but I have a real physical, disability or something going on in my body. It's real. I'm not just emotionally making it up. Like, how can you answer that? Yeah.
Yeah. We always start with, yep, what you're experiencing pain wise or whatever else is definitely real. Um, so we usually go back to your brain is the pain thing, and your brain is creating pain from whatever it's reading in your body, whatever sort of, tensions or inflammations or whatever nerve issues might be there. And it's probably adding a piece to it that might be coming from these emotional things that have been blocked. I usually, I'm not a physician and I don't know that I have magic answers to figure out how much of your pain is coming from what. So I'll invite the person to experiment with me and let's see what we learn. And by the way, Grace, if it turns out that I'm wrong and it's actually mostly driven by what's going on in your body and not much to do with emotional stuff, then matter of fact, you can even tell me that I'm wrong. Could you practice that, by the way, Grace? Just saying, Mark, you were wrong about me. Give it a try.
Mark, you were wrong about me.
How's that feel saying that?
Okay, but a little uncomfortable.
Good, good. You did it pretty easily. There's a set of people who's like, I can't say that. No, and then their alarms go off about having a voice like that. So I
Hmm.
actually do that little bit of weird stuff, inviting a person to try some new ways of expressing themselves.
Hmm. Yeah. I would imagine that would take probably time too, right? Especially for someone who's never been able to do that, or especially in front of someone that they're just getting to know and to meet. That can be pretty vulnerable. Yeah.
Yeah. So, I mean, a couple of parts there. Yeah, it does take some time. We can't do this in 15 minutes usually.
Yeah.
But I'd say, are you feeling vulnerable right now? And you'd say, yeah, it feels really awkward. I don't know you, Mark. And I'd say, cool. What shall we do to make that easier for you? And I'd say, how about this one? Practice saying this, Mark, accept me the way I am. And I don't really trust you, but well, I might try something like, I want to trust you, but I don't, Mark. I just want you to know that. And I invite the person to be honest with me along those lines, or something like that. But a lot of these things, a lot of these issues can be worked on more quickly than many people have thought. In my field, clinical psychology, many people have thought it takes a long time to do this work. It takes months, years. A lot of things can be done much more quickly. You have to believe that people have the capacity. The person across from you has the capacity, even though they're scared and they're new and they don't know
Mm.
you. They have capacity. They have abilities.
I know from going through a EAET training, you're right, it is a mouthful. That that there were a lot of practitioners that were even a little bit nervous about getting into this work themselves, being the therapist, being the coach, being, someone who leads this, which was interesting to me. I mean, I think it makes sense, but I mean, yeah, there's both vulnerability on both sides, I'm sure.
There really is. I do a lot of work on training psychologists. That's part of my job at the university. And I often have to do the work of helping people go from, I want people to like me and I want people to be comfortable and calm and happy all the time, my clients, my patients, to I need to be able to help take them to a difficult place, even though they're going to become anxious, even though they might show anger. It's interesting. We recruit people into our field who are great at social skills and good at working with others and have great ability to make people feel comfortable. And then I ask them to try to do something that maybe doesn't work in that direction. That's hard. At this point, I think there's only some people can do it and other people are sort of really too uncomfortable to do this work. And I suggest they don't, and they can do other things. Personally, I've had to do some of this work on my own therapy and my own life to try to develop more capacity to do that. But it really helps when a person comes to you and says, Mark, I'm in pain, I'm struggling, I'm suffering, help me. And then I'll invite them to do some work. And most people are like, yeah, I need to do this. I'm scared. And I'll say, you can do this. Let's do it together. And then we work together and move forward. It's really kind of beautiful.
Yeah. I mean, it does take, I've learned that as well. It takes my own work to be able to do this too, because I mean, yeah, I come from a place where it's super vulnerable and not okay to express or feel or take up space or, not make, but help someone else be uncomfortable too. Because to your point, being uncomfortable helps us change
Yeah.
and learning
Yeah.
how to shift that. Yeah. Yeah. Okay. Can we go back to when you mentioned journaling, when you've been doing
Yeah.
some
Yeah.
study? with Baker. Can you describe a little bit more of that work? I've talked a little bit about journaling on here, especially Journal Speak by Nicole Sachs and things like that. But I think that could be really helpful for our listeners to understand that piece of it, the journaling piece.
Yeah, there's a bit of a disconnect between the research on it and the practice of it. And I came from the research perspective.
Okay.
So Jamie Pennebaker developed this paradigm. He's a social psychologist who wanted to see if you could help people sort of give voice to whatever they hold inside, will it help their health? And he developed a simple experimental paradigm. Randomly assigned some people to write for a few days about difficult experiences they've had and their deepest feelings, and other people, a control condition of people randomized to write about neutral things, for example, and then follow them up, both groups, to see if the health improves of the first group relative to the second group. And he did that with a bunch of college students. We ended up doing this work in people with fibromyalgia and rheumatoid arthritis and asthma and a bunch of other conditions. We did probably 15 studies over the years, sometimes talking out loud, sometimes writing, sometimes typing, sometimes with a guide who's getting some feedback to you, lots of different, sometimes keeping it completely private and other times turning it into the research team so somebody sees it. We tested lots of different ways. The bottom line was that several things. I was amazed that most people are sort of ready and open to share some stuff that they might not normally share when invited to. So, Pennebaker was stunned that people actually have been through some stuff and they're writing it out. And I too was often stunned by what people, when invited, when instructed, please take a risk and do it, would share. That was number one. Number two, the effects were not that big. They're actually pretty small in terms of the magnitude of the effect on health. And there's lots of reasons for that. I think partly it's you're comparing it to a control group that's doing some writing and you kind of look at the difference. Partly it's an experimental thing and you're randomly assigning people to do it. And it's a little sterile in the research environment. But study after study showed the effects were pretty small. And so that's a little different than what happens clinically. And we use it now clinically. And it's much more about the clinician working with the patient to say, let me see if I can give you some guidance on what to write about. And maybe you want to bring that writing, see what you do with it and what you learn from it. Maybe we can talk about it next session. Matter of fact, what would it be like? Personally, I like the unsent letter as well, which is not what we tested experimentally. The unsent letter is probably the most powerful one. What is it that you wish you could say to so-and-so, but write it out as honestly as you can, but don't send the darn thing. And we'll actually invite people to bring it back to session and even read it out loud or as if they're reading it to the person sitting in the empty chair there. So I think clinically, that's what Nicole Sachs also finds. Clinically, it's a lot more powerful than perhaps done when tested in these somewhat sterile randomized controlled trials, which is what we've done a lot of. So we use it as a homework exercise now. And many people will say, actually, I heard a woman say just last week, she said, I didn't do it. Why not? It scares me to see it in print. And I said, okay, well, let's maybe think of some other ways to move towards that goal so that it doesn't scare you as much. But it was a huge flag of this is needed, needed, difficult, but needed. And see if we can work some ways to get you there.
In this study, I'm just curious, were there instructions about how to write about something difficult? Meaning, like you mentioned in the beginning, instead of just writing about, oh, I was frustrated or, oh, that made me a little annoyed, instead getting at the anger or the disappointment or the despair, the sadness. Was that part of it?
Yeah, the original instructions that Pennebaker developed were very innocuous. They didn't have any direction for it other than be honest and don't worry about your grammar and your spelling and your sentence structure and stuff like that.
Yeah.
But there was no more guidance than that. And the hope was people would be able to do something with it. My observation reading many of these writings over the years is that while people will talk about an experience they've had, they may share something, they don't know what to do with it emotionally in the writings. They often will kind of just ruminate about it, talk about their frustrations or their helplessness or the sort of emotions that I think are sort of secondary rather than the primary adaptive ones. I'm depressed and I'm anxious and I'm feeling stupid and that sort of stuff. And they don't know what to do with it. So clinically, I think you have the opportunity to help a person direct their writing a little more. I mean, some patients blow my mind and they can do it, but a lot of people need the extra help. That's one of the things that moved my research from expressive writing, emotional disclosure alone as a standalone technique, to integrate it into this larger EAET thing we're doing as a homework, as part of the homework.
Let's expand on that a little bit more. What do you mean then by maybe people will write about something, but they don't know what to do with that emotionally? What's the disconnect there, and what is it actually we're trying to get them to do?
Yeah, I mean, Most commonly, and I don't know if I want to use the word unconscious or not, but people are minimally aware of certain emotional experiences. Classically, let's take a woman who was sexually assaulted. Far too common, and they might start to write about it. They rarely write about themselves becoming powerful and kicking that guy's butt. Or, they write about their shame, they write about their disgust, they write about their numbness, they write about their dysfunction. They're revealing some things, but I don't consider most of that the right direction. What almost always is buried in there somewhere is anger or rage towards him, right? And that's the piece that's been smushed down, suppressed, moved away, something. And that's the part that needs some help. And then the second big category is things in the family. The families are even more complicated because there's almost always two sets of feelings. There's the anger and the longing for love and closeness from somebody. And those things are in such conflict that the person often doesn't quite recognize either of them. They're just sort of feeling stuck and wanting to get out or something, survive. And so much of our work, whether it's in the expressive writing, but especially in the therapy, is trying to help people experience some of what those feelings are, build them a little bit inside them, recognize them, and give them permission to be expressed. We sometimes have to guide people along a little bit in that process.
Yeah, the families one where I'll also, maybe it's around this, but add to it where there's also a protection factor, right? Where I've asked, how did you feel about that with your parents and how you weren't able to express, or how did that make you feel? And they're hesitant to say it because they don't want to be mean or say anything bad, or, well, they were there, right? That kind of thing, the almost dismissal. So there's that second layer of protection where it feels like if I express actually how I feel, it's really bad or mean.
Yeah, yeah. And I think I hear two parts happening there. One part is I've learned that I need to be nice in general, and so I'm not going to do
Mhm,
that.
mhm,
But this other part, which is really important, is I long for something from that relationship: attachment,
mhm,
connection,
mhm.
love. And it's anger threatens that. For me to voice disagreement, anger, assertion, push away, it risks pushing away and me losing them. So I need to hold on to them. So one of the exercises I love to do with folks, even in the audience, I'll ask people to
Mhm.
pair up and simply practice role play, fake it, being assertive to the person next to you, like as a partner, saying something strong and assertive. And it's hilarious to see how people, even though it's been given explicit permission, people will start to go and they'll giggle it away. They'll reach out and touch. They'll reconnect in some way. They'll apologize. I don't really mean this, but they do a number of connecting behaviors. And by the way, if I do the other side, I'd like you to become as vulnerable as you can with that person and tell them your deepest, darkest secret. Go ahead. People will go and they'll actually put up a little bit of a wall, a protective wall, right? That's both of those are good. I mean, you need the protection wall and you need the connection, but it becomes an example for many people of how they are uncomfortable being too assertive or too vulnerable. And they end up creating kind of a narrow band of comfort for themselves. One way I like to think of growth is expanding the zone of comfort that we have from if I go too far to the assertion, it scares me. If I go too far to the vulnerable, connecting, open, vulnerable, it scares me. And what we need to do is help people expand that.
I like that zone of discomfort, or did you say discomfort or comfort?
Probably
Discomfort.
the discomfort
Yeah,
zone or
it would be zone.
whatever. It's too narrow. The comfort zone is too narrow. We got to
Yes,
broaden it.
exactly. Yeah, I use a window of tolerance, but actually that kind of describes the feeling orientation of it. Yeah, yeah. Okay. Okay. I think this is going to be really, really, really helpful. We talk a lot about mind body connection and understanding what happens with chronic symptoms, but the
Mm.
emotional piece, I often find people um, they skip over a little bit more because I think it's really scary. I think it's probably the scariest part of a lot of this is to go there. And it's also
It's
just
scary.
not understood. It's hard to grasp when you've never actually felt it.
Yeah. And, where people will say, oh, it's just experiencing emotions. Actually, you have to do some assessment of which emotions need to be activated or experienced. And there's almost like two layers. There's the superficial layer that people bring in, and then there's the underlying layer that needs to be accessed. And that's not easy stuff for
Mhm.
people,
Yeah. Yeah.
for clinicians or clients.
Yeah, exactly. Exactly. There's plenty of other therapists that I know that don't do this work that have no idea. They don't, maybe not no idea, but just don't really get it. They don't understand, right? I was never taught this in school. I've had to seek this out, but I do think it's really exciting for where it's going because it feels like there's a lot of momentum around awareness and helping people understand this work.
Yeah, I'm excited about it too. Though I've also been involved with the pain reprocessing therapy world, so I'm doing research on that with my colleagues. And what I am currently thinking is that's a great starting place. It doesn't do much with emotions. It
Hmm.
focuses more on people's experience of their body and their fears about their body and movement and pain and what it means and how to reverse some of that. In our current clinical trial with people with back and neck pain, we start with some PRT stuff and then we build onto all the emotional stuff. And there's a set of people who get better with the PRT pieces, the pain
Hmm.
reprocessing pieces. Give
Hmm.
them a new model, a new way of thinking about what their brain is doing, and it's like, whoa. And then there's a number of people who we need to do a lot more. Yeah. The patient who said to me not long ago, she said, it's really strange. I have back pain when I bend over, but only when my husband's around, not when I'm alone. That is, well, there's issues with that husband. And we dug a little deeper. We found the issues with the husband. And these things happen in many, many patients. There's this sort of interpersonal piece that activates the emotions. And I realize right now, I didn't say much about relationships, but EAET doesn't end with just doing emotional work. We encourage work on actual relationships. And that means often as you learn what you actually feel and need, figuring out how to best communicate that in the real relationship. That's really scary. But when people can make that step, it's really healing as well because they've learned either new boundaries, they've put up some new boundaries if needed, they've connected in ways that they've not connected. And we help people. Usually people are stuck in relationships and they need some help figuring out how to work those things in a new way. And the emotional work first really opens up the pathways to working on relationships. And when people make those changes, not only do they say their pain is a lot better, but they say, I'm a different person. And that's really cool. You don't see that much with pain reprocessing therapy. They say, that's nice not to be in pain.
Hmm.
With EAT, a lot of people say, I'm looking in the mirror and I'm looking at a different person than I was 3 or 4 months ago. I'm feeling different in my relationships, feeling more capacity to engage in life in ways that interpersonal ways I've been avoiding, whatever it might be. I'm more able to be communicate. One guy said, it's really strange. I used to be bothered with letting my kids win in little competitions. He says, I actually am comfortable letting my kids win now. That's really strange. He became
Hmm.
comfortable with his own skin of who he is in his emotional life, and it showed up in his relationships.
That was going to be my next question is, okay, if we're working on the expressing emotions within ourselves, does that also mean, it's kind of the question people ask, do I also have to change things in my life? Or maybe there's something big that I'm realizing. Is it enough just to express it to my therapist or my journaling practice? Do I actually have to change something in order to get out of pain?
Some people do, and some people don't. I think is my best guess. There's some people who can do the work in here,
Hmm.
and in here, and it actually takes away the pain or reduces it greatly. Some of our fibromyalgia patients who've made the best success are people who've made major changes in their life. I'm thinking of one who got rid of the pain in her butt, called her husband, who was a bad husband. And she talked to me 6 months later, says, I'm free from him and I'm free from fibromyalgia. And I think they're connected to each other. Another woman said, I realized I've got an alcohol problem and I needed to go to AA and I've been avoiding it for years. And that moved in my life is the huge thing that made a change in my body, you know? So, and sometimes they're smaller. I finally talked to that roommate that I've been avoiding dealing with the issue in our room, our shared space. A lot of things that happen like that. I think it certainly adds to the benefit, though some people might not do. But I think in general, you probably need, well, hopefully, the emotional cognitive work that you're doing in therapy session will actually change behavior in mostly interpersonal behavior out there. Let's hope.
I also wonder, I mean, I've noticed too that once you do enough work within yourself, interpersonal, sometimes, not all, but sometimes it's almost hard to continue with the same either type of relationship or job or whatever it is in your life. There's a disconnect there.
Yeah, yeah. As you discover what's more true for you, as you discover what your needs really are, many people will say, I need to not take that anymore.
Hmm.
I'm going to finally speak up. And that might be a big change. I'm going to change jobs. I remember one woman we worked with, and she ended up saying, I needed to make a stand with my boss who had promoted the guys above me, over me several times. And she said, when I finally did, I felt this thing happen to my body. It was just huge. That would help that the boss actually heard her and said, you're right. That helps. But her
Mm.
being able to find the courage, the ability to say, I'm important and this is not fair. She'd worked on that in therapy, imagining her boss and being able to have this conversation. And then she played it out in real life.
Mm.
So that's scary stuff,
Hmm.
but it can be really healing.
Yeah.
And if
Yeah.
if you therapists out there are really feeling gutsy, would you ever bring in a person from the person's life into the session? in order to have your patient client practice being honest. I'll share a real quick story. One of my favorite patients, fibromyalgia, she had been for 30 years struggling with it and struggling with her very domineering, feisty mom. And she was scared of her mom ever since she told her mother, shut up 30 years ago, and mom got angry with her and she's been sort of intimidated. I said, I got to meet your mom. And she said, oh, no. You don't want to meet my mom. She's really, and I'm scared. And I said, we got to do some work to help you at least be honest with your mom. And she ended up, after a month of talking about it, brought mom in. And mom was a 75-year-old feisty lady. What are you doing here? What am I doing here? Blah, blah, blah. And she ended up, I asked if the patient could tell her mother, shut up. I can't. Can you tell her what you want to tell her? Mom, I want to tell you shut up, but I'm afraid to ever since 30 years ago. And mom looked at her and said, why are you such a scaredy cat? Why don't you speak your mind? Well, I don't think I'd like it if you told me shut up, but you should stop being a scaredy cat. That's what the 75-year-old told the 50-year-old mom, right? 50-year-old patient. That was the extent of our session mostly. And I see the patient the next week and I said, how you doing? She goes, this is the weirdest thing that's happened to me. For the first time in 30 years, I went to my mom's house, who just lives a few blocks away, and I didn't want to run out of the house in pain. I was able to be there comfortably for an hour. I said, did your mother change? Oh, no, she's still the same way she's always been. What happened to you? Something happened in my experience of myself and her that I didn't feel scared anymore. And it took, I'd worked with this woman for a long time privately, and it took her finding the courage to say something to her mom, like, I want to say shut up to you, but I'm scared of you. And that was the piece that allowed her to grow in a way that she had never grown before.
Moments. It's hard, I think, sometimes to believe that they can be that powerful.
Yeah. When people have been scared and avoidant for so long, being able to take a step towards what they've been scared of. Yeah. I'm no longer that scaredy cat. I'm somebody who can have a voice. Somebody who can do something. Or I'm somebody who can hug and connect and trust and cry. Maybe cry if I've been avoiding that one.
Yeah. Yeah. You've published over, correct me if I'm wrong, but over like 200 papers and been funded by the NIH. What excites you about most where the mind-body field of chronic pain and symptoms is going?
Yeah, I'm seeing this movement in lots of places to say pain doesn't have to be something we just live with and manage, and that the brain is really important. And pain can be many people's pain, at least something called primary pain or the neuroplastic pain, if you like, can be really quite reversible for many, many people. And I'm pretty tightly tied to the academic community, the scientists and the world of this stuff. And many of them have been skeptical, but they don't have to make out of me because I'm a mainstream research guy who also believes in this other model. And I've had lots of conversations with my colleagues who are starting to come around and say, maybe there's something there, And so that's exciting to see the kind of old guard who've been kind of stuck in a certain model loosen up and start to see new ways of operating. Yeah. That's really kind of cool. Now, if we could NIH to put forth more money to it, it'd be nice too, but that's a hard one right now.
And is that mainly with other clinical psychologists, or are you talking all different types of professionals?
Yeah, when I go to the major pain meetings, the pain meetings nationally and internationally, and I talk with colleagues, I'm just seeing more people across the spectrum who are more open to these models than they used to be.
Yeah, good, cool. Yeah. Thank you so much for all the work that you've done. It's really powerful, really helpful. Yeah. Yeah. Is there any words of wisdom that you could leave us with for someone who's feeling really stuck in their chronic health journey and they're obviously listening to this, so they're maybe thinking, okay, maybe something is a little more than just the structural treatments I've been chasing for the past however many years. Like, what would I do now?
Yeah, open yourself up to the possibility that what goes on above the neck is actually really important. And the most important part of that is the things that are tied with your emotions, your fears, your emotional needs. Anger is often a piece of that buried somewhere, but for other people, it's the need to be able to cry or to connect, to feel vulnerable. But for a lot of patients, it's the blocked anger, the blocked assertion that comes from that, the ability to speak their mind, to say no, to say stop, to say this is what I need or want, and to try to find the right, in a safe place, therapy or privately, to find your voice in giving that some expression. I encourage people to privately empty chair and put dad, mom, sibling, whomever, professor, whomever it might be in that chair that needs to hear your voice and practice some expression and see what becomes of your body in the process of doing that. And if your body starts to have a reaction to that, that's meaningful. means there's something's connected between that emotional experience and the bodily experience. And there's hope then to move that bodily experience in the right direction.
Go that and say that most of the times when I hear people feeling stuck in this work, it's usually because, not everyone, but a lot, it's because they've done maybe some of the brain training, or they've understood or read a book about the mind body connection, and they're maybe finding a little bit of progress, but they're still feeling stuck, is that they haven't gotten to the emotional piece yet. And I find it's such the core so much of this work, and the body sensations and all the things that happen in the body. So if you feel like you're stuck in that place, highly recommend navigating and searching more in terms of this emotional work, and listen to this podcast again.
Yeah, yeah. And I think there's a lot of therapists out there. You won't find many therapists who've been trained in what we're doing. It's still kind of new. But if you ask a therapist, please help me dig into my emotions and go there with me. I mean, you actually sound strange, but a patient or a client could actually ask a therapist to take them to a certain place. Many therapists will sort of do that. It's they're nervous unless the patient says, please help me go there. And then therapists have permission, and they're more likely to help a person go there.
Yeah, that's true. That's true. And hey, maybe send them this podcast and say this, I listened to this and I want you to help me go here. Yeah. Yeah. Cool. All right. Thank you so much again for showing up and coming on and sharing all your wisdom. Really appreciate it.
My absolute pleasure. Thanks, Grace. You're amazing, by the way. Amazing, Grace.
Thank you. We will see you next time.